you, Dr. Stephen Chow, for kind introduction. A very good morning, ladies and gentlemen. It's a pleasure for me to be here again. And of course, when we are talking about harm reduction, it's always a big challenge which we have to face. And definitely, we get a very good help from many of the GPs. And definitely, I always consider Dr. Lim and Dr. Stephen Chow as what we call respect experts in dealing with harm reduction. And in fact, when we were challenging the GEG, we want to know who actually we should contact as our respect experts. And straight away come across my mind, I must bring Stephen Chow to be one of our supporters. Okay, so the topic that I'm going to discuss today is still very hotly debated. Some agree and many still didn't quite agree. And it's related to tobacco harm reduction, the way ahead. And the paper for this presentation is also prepared by Professor Tehereh, a psychologist from Iran, my wife, and Sharon Lillian Howe, a psychologist who is now working in my department. Ladies and gentlemen, let me start with a basic fact about smoking. We know that it's the worst form of drug if you categorize into the severity of its addictions. There is a lot of conditioning process like any other form of addictions. It is a very complex disorder. But on top of that, there's a wide range of forces that make it much more difficult. It ranges from the social modeling, the advertisement, to the politics and the economic, and of course, it also involves international trade. And hence, when you are trying to suggest how to manage a patient who has a problem with nicotine addiction, the situation is not as simple as when we are introducing harm reduction for heroin dependent syndrome or any other illicit drug use. I want to narrate what has myself gone through to so-called trying to zoom into smoking cessations. There was a time when the Ministry of Health is proposing Tak Nak campaign. And I remember I was there together with some committee members in MMA, and they want us to endorse and sign the campaign. I don't know, you can call it, I'm a bit rebellious. I said, no, I don't want to sign. Why? Because it looked like the campaign is more like billboard advertisement. And I say it cannot be something that you fork out 20 million per year and you expect any result. So I'm among the few. Another one is my pediatrician friend. I offhand can't remember, also refused to sign that Tak Nak campaign. And apparently, it took about 100 million worth of a campaign. And what is the result? The last that I contacted Dr. Zariha, who is now also already retired from Ministry of Health, he promised to me about giving the idea how effective it is until to the very last. She didn't give any of those. Then it come into quit smoking clinics. And I also involved in that. In fact, we went to Hilton, we went to Selangor, pewter factories, we went to even Malaysian Oxygen, trying to study the effectiveness of smoking clinic. And it's very sad to say, the clinic is there, but the patient never come to so-called get the treatment from us. And apparently it goes similar in what has been smoking clinic in the Ministry of Health. There's nothing much in terms of its effectiveness. The efficacy might be there, but efficacy is not there. But we try as much. We try to gather, a lot of interest among doctors so that, in the end, maybe we can finally get more doctors to be involved. But toward the end, even the doctors themselves also is wondering whether it works or it doesn't. We have a lot of laws and regulation, but the problem is that enforcement is not really, bring the law into practice. We have a lot of fear tactics, including what we already see in our cigarette boxes. But who cares, All the gory picture was there, but it didn't really give that much. And another resistance from our group is when they want to introduce GEG. And I will tell you what exactly it is. We've gone a long way. We even call all those, religious leaders. And I remember Nick Aziz, our late Nick Aziz, even labeled these smokers as animal. But does it matter? Not really. They still smoke even in the mosque. And even the imam joined together with the rest of them to smoke. Zero tolerance for total abstinence. There was one example here whereby the religious teacher changed their student who found smoking. Does it really work? I doubt about it. I went to Sudan when I am supervising one of my PhD students. The Sudanese, it was about 10 years ago, even locked these people in this hut with the very minimal basic amenities. They don't even have toilets in this place. But this really work. They come out and they go back to their smoking. Another very desperate attempt is also coming up. I thought it's only Sudanese doing that because they don't have enough doctors there. But in Malaysia, they don't even mind to be killed through what they call, traditional killing technique to manage smokers. What they did, they stormed this smoker, the bomo, stormed the head with a hard object until he died. Of course, when he died, maybe, that's the best option. So, and I've gone through trying to convince GPs. That was the first time is mooted by Chiba Gegi when they actually marketing nicotine chewing gum. And then following that, another campaign is when Pfizer is introducing varenicline, also targeting the GP. But it didn't move any needle. We still have at least 46% of our adult population who is smoking. And the tobacco-related deaths seem to be still a problem, which are faced mainly by developing countries. I was invited to World Tobacco or Health Conference in Beijing, and that was when Deng Xiaoping was just, elected as a president after Mao Zedong. Of course, it really presented a lot of what we should be doing in terms of policy against smoking. But what I observed, when he came out from the officing ceremony, I saw him smoking before he went to his car. So, well, it goes without saying, policy is one thing, law and regulation is another thing, but what people do at the back is definitely another thing that we have to only be observed. Yes, there's a lot of issue in terms of how smoking is not just going to influence the primary smoker, but also the secondary smokers, and or what they term as environmental tobacco smokers. They might be the same risk as the smokers in terms of their health problem. This to me is a very classical, because recently one of those opponents of tobacco harm reduction among cardiologists, including my friend Dr. Rahal. Why it's very interesting to come out with this classical paper by Yama is because these are the selling point when I try to convince GP to be involved in smoking cessation. Let's see here, if, for example, we manage patients that come to us through smoking cessation, the NNT, which indicate the effectiveness of our approach, is 9. Compared even preventing cardiovascular illnesses through lipid lowering, BP control, you can see the number is definitely higher than 10. Anything, when we talk about NNT, the NNT number need to treat, anything higher than 10 is almost like you're talking about placebo. So I sell this idea to the GP when we were with them, talking about how effective if every GP were to involve with smoking cessation. It's much better even with lipid lowering that costs, in terms of cost, is definitely higher. But I will tell you what is the problem. The problem, we go back to the idea that we are dealing with the worst form of addiction. The problem is that the relapse rates among smokers is almost 95%, whatever you did. And this is based upon the study reported by the MBA. And these are the things that give us a lot of frustrations. The efficacy is still yet to be observed. If we just confine to smoking cessation, if we talk about only giving nicotine replacement therapy. And then came the first oral smoking tablet, anti-smoking tablet, called Viraniclip. We managed to work together with Professor Fergostrom. In fact, he came down to give a good presentation about Viraniclip, which is alpha-4 beta-2 partial agonist. Apparently, it's very effective, And we don't really need to go to psychotherapeutic intervention or very complicated hypnotherapy and whatnot. So what we tell the doctors who is interested in this smoking cessation treatment is that what you need is a simple advice. What you need is what we term as 5 Ks. You don't need to worry about psychotherapy. You don't need to worry about, because many doctors won't be sitting with a patient for 1 hour and you expect them to treat the smoker. So we tell them it's not at all a rocket scientist. You don't need to be a psychotherapist. What you need is to apply 5 Ks. I'm sure some of you are very familiar with it. So it looked very simple. It looked as if, nicotine replacement therapy, if we look into some of those study results, are very effective. And Viraniclip is also equally effective. We see the result is like the 52 weeks relapse prevention is almost carry a p-value of 0.0001% to suggest that it is definitely not due to placebo effect. But what is in reality? The reality of it is that patient take the medication and then came to us, only few sessions, and after that disappear. Some of them telling us Oh, doctor, it's very expensive. I might as well go to cigarette rather than to take your medication. So, do we have a choice? Do we still need to continue only for smoking cessation and nothing else? And this goes back to the fight we have when we actually apply the same concept to treat heroin dependent syndrome. And it took us how many years, Dr. Stephen Chow, before we managed to get it endorsed? It was 15 years. They always ask for what? They always ask for, where is your evidence? We give evidence. No, this is evidence based upon America, Europe. We want to have local evidence. We give local evidence. What they said? Local evidence. Oh, we will look into it. Until Tan Sri Chua Soy Lik. Just by coincidence, he is also our alumni. You know him, how he works. He said, okay, Hussain, you just do whatever you want and let me take the decisions. It took me 15 years after we have 85% of our heroin-dependent patients died as a result of AIDS. Then only we managed to endorse. And it goes similar here. It looks like it's going to be a challenge here. We have a lot of resistance now. We have put up our option paper. Prof. Sharifah is going to tell us more about that. We have put up white paper recently to our Minister of Health. And thank God, now we finally see the light in the end of the tunnel. In fact, the first impression we get is from our Prime Minister, Dato' Sri Anwar Ibrahim, who said, GEG is too regimented. So he wanted to have some changes in the GEG. Ladies and gentlemen, whenever we want to look at all those concepts, it's not my scope to discuss about stress diagnosis model in addiction. But what I'm trying to highlight here is smoking-related disorder are actually the problem of the poor B40. And one of the concepts that was highlighted in stress diagnostic model is chronic stress. And why a lot of B40, the poor, are the one that is most at risk to smoking and also in addiction, is because they were the one that actually into chronic stress. Of course, there might be some genetic, epigenetic, and other environmental factors. But one of the biggest issues why a lot of smokers and addiction were those from low socioeconomic is because of toxic stress related to their poverty. But again, I will actually discuss why I specifically look into that, but yet look into the etiology of all disorder in order for us to be very specific what to deal with this type of disorder. Actually, harm reduction is nothing new. It not just applies only recently. We have been doing it with heroin. In fact, it can apply even to prevent injury due to motor vehicle accident through helmet, we even apply in medicine, in diabetic mellitus and other metabolic syndrome. We also do apply some of the concept of harm reduction. But what is the skepticism when we are trying to introduce tobacco harm reduction? Well, some of the comment that was highlighted now from those who rather against the concept, they said, oh, probably it derived from tobacco industry. Okay, if that is the case, why don't you say the best option is to close all the cigarette company? Why must you only attack on e-cigarette, on vaping? the best to stop people from smoking, and I expect it to come out in GEG proposal, is close all the industry. Why you should discriminate people who smoke? If you close all the tobacco industries, there is actually reaping billions and billions. Definitely, there will no one there to smoke because there is no cigarette anymore in this country. Why don't you tell that? Why you attack vaping? Why you attack e-cigarette? And we try to put e-cigarette and vaping is because we want to make sure that it is less harmful, because we know the cigarette contains much more polyaromatic carbon that cause all those diseases. But we never, in our right sense of mind, telling that we want to make vaping and e-cigarette as a recreational drug. No. We do not want that to happen here. We want to make sure that all this must be according to harm reduction medical concept. We are not propagating recreational drug, recreational vaping. And there is no issue, like recently what come out from the Penang, what you call, Consumer Association, who tell everybody that, even 5-year-old is now vaping. No, we never say that. We never tell that, it should be in the form of recreational. But what we want is to come up with a better protection to health. We want to make sure that whatever we want to propose in harm reduction is finally translated into preventing health-related problems due to cigarette use. But this is all about clinical judgment. Like it took 15 years for methadone, it's because of clinical judgment. Why judgment? Because when the measure to judgment is got to do with human mind. But let's not forget what has been quoted by our father of evidence-based medicine, David II. What did he say about evidence medicine? And I always emphasize this among my medical students. By the time you graduated, 5 years after you graduated, 50% of what you learn now is becoming obsolete. Okay, 50% is becoming irrelevant. That's why we must keep in touch with all those evidence to make sure that, we are not fall into the flaw in our clinical judgment. What do we expect when we talk about judgment is to have as accurate as possible. It is not sometimes equal to good judgment. And the goal of judgment is not to impress and not to take stand and even not to persuade, but to make sure that in the end we make sure that our judgment is out of being biased, out of having some effects that is not the actual target of what we want. And when you're talking about smoking, there are so many factors. And some of these cues can be very difficult for us to identify and gauge before. And it's the reason why tobacco harm reduction is becoming a long battle and is still a debate. But it was the same thing. When we want to produce, when to introduce methadone maintenance program, UNODC, we have a meeting in Canberra. Those days, UNODC do not want to accept our harm reduction. So we are divided. One pro methadone, the other against methadone. The UNODC is like, no, the WHO said no such thing as tobacco harm reduction. These are all the ploy of tobacco companies. The same goes. And I remember going back to Malaysia, My good friend, Dato Nawa Ranam from USM, when I tabled the proposal for us to introduce methadone, I remember he told no, we should go to naltrexone because that's the one that actually make sure that the patient do not take heroin. But naltrexone is an opiate antagonist. It won't attract heroin. And I remember it took him for a while before, we managed to get over with that argument. So how to make a better judgment? Maybe we have to look into all this judgment strategy, debiting, decision hygiene, like washing a hand to prevent all this bacteria that can influence our flaws of judgment. We have to look into our critical thinking. We have to apply not only our crystallized intelligence, but our fluid intelligence. We have to be open-minded. We have to be thoughtful. So, of course, there's a lot of other approach now, which maybe Prof. Sharifah can advise us, like using algorithms to improve our judgment. Now we are talking about AI. In fact, it has been quite some time. It was mentioned that now the radiologist's work might become obsolete because apparently AI can actually identify the radiology imaging better than our radiologists. But definitely we need guidelines, we need standard, and we are not just, without all this support. Well, the issue is that there's a lot of things which I was against GEG. And that's why we come out with a petition paper to Khairi Jamaluddin and who else? To Dr. Zul and also to the parliamentarian. We are fortunate. We don't have any more choice really. If we have choice only, maybe he can just straight away, helping us. But we have Andrew Sim, isn't it? We have few parliamentarians who is actually backing us. But that is now Choice Sele is one of our board member in Masa. I used to see him, and he still remember that you are the one who actually worked with us introducing methadone. Yes, but Tan Sri, you are the one who actually create all the changes. You are our agent of change. Because he just bulldoze. And make it through. So what what is the problem? Why we go all out? Our president is here, president of Harm Reduction Malaysia, because it's like we repeat the history of how we deal with heroin. It is a draconian approach. They apply zero tolerance. You imagine, the first idea is they want to fine 5,000 ringgit for those who are caught smoking, or for those who actually carry some of this paraphernalia to school. How you are going to implement that regulation when many of those smokers were among the poor? Actually, the definition of B40 are among those who actually their income is less than 3,000 ringgit. How are you going to impose 5,000 ringgit? And then they go down to 100 ringgit. And finally, they go down to 50 ringgit. You imagine, even 50 ringgit is still beyond, for many of those poor to pay. And where they are going to end up if they cannot pay? They will go to prison. And this is what happened to our addict now. Just because they show urine positive, they charge, flogging, and they go for imprisonment. And what happens if they go to prison? Who is going to support their family? Who is going to actually take care of, and they will definitely lose the job. 99%, this study by Professor Mohsen, 99% of now who is inhabiting prison are among those who is among the poor. Why not the rich? Because they are backed by good lawyers. And our XPM not only good lawyers, they are backed by politicians. So definitely, they might have the similar risk, but the poor are much more in prison and in food quarantine. So how can we allow this to happen? And just because they are smoking. So that is the number one where we get together, including Dr. Stephen Chow. He is also the support for this, what we call petition letter and also white paper. Have you passed your white paper to Dr. Stephen Chow? Better give to him because he's among the our fighter here. So it will definitely affect. If we go into DED muted by KJ, definitely it's going to affect the social mobility, the inequality, and it goes without saying, Malaysia are among the worst in terms of corruption index. So all this thing is not going to help. So that is why we look hard for studies. We are not just into this is one of the criticism that was put up by Professor Haneke, saying that the tobacco harm reduction specialists are not based upon the study. Come on, we never want to do something without into the study. We have a lot of support evidence to suggest that tobacco harm reduction does actually help the smokers. And this is one, I just put this photo. This is one of the biggest environmental degradation if we allow the smokers to continue smoking. Okay, the pollutant due to cigarette butt and cigarette box is now maybe, cause a lot of environmental damage. So if we go and translate it into even combustible cigarette, or e-cigarette, of course, we definitely, one thing we hope to see is there is no more cigarette butt thrown all over the place. Well, what do we get from KJ after all the petition we sent to him? KJ make a statement in the news. That was before he lost his election. Whoever that said about THR, they are classified under BS, bullshit. So the bullshit goes to those who send petition letter to him. But is that something that make us giving up? No, that's what veteran Russell said. Do not fear to be eccentric in opinion, because for every opinion now, accepted was once accepted. So what is that bullshit? And in fact, GEG, generation and game, become generation election game for KJ. Well, I can say it's karma, I don't know. Well, another quotation. I was initially thought that this quotation is from Einstein. Apparently, it's not. I found that, this quotation is even highlighted, by Chinese scholar and by Mark Twain. It's not by Einstein. And what it say, if we doing the same thing and we just back on the smoking cessation as the only way to help smokers, probably what the result is not going to be, materialized, because this could apply to the definition of insanity and plus stupidity. Okay, this is not my quotation. Okay, so my conclusion is that THR is a complement, is a substitute. Whoever want to put up, other treatment design, please do so. Whoever want to actually still continue with the smoking cessation program, who want to go for nicotine replacement therapy, who want to proceed with bupropion, who want to proceed with what? Cantic or varenicline, please. We are not actually against all those efforts. Even though myself gone through that kind of failure attempt, but we are not actually preventing anyone to proceed with that kind of evidence. But what we want is to also include tobacco harm reduction as one of the options. And the argument about tobacco harm reduction should be based upon facts, fakta, rather than auta. And the reason, of course, now the government has gone into the 360 degrees by allowing vaping to be what you call by giving a permission for vaping product to be sold. But that is also not going to be our objective. We do not want vaping product to be sold without any regulation. We do not want any use of smokeless cigarette to be subjected to be in the form of recreational. We want to make sure that all must be regulated. We have to make sure that even the flavoring that apparently contain a lot of de-acetal that give a buttery flavor to vaping, that should also be regulated. Because now people talking about what? People talking about popcorn lung, e-vali. But this is got to do with de-acetal. And de-acetal, the content, the percentage of de-acetal is higher in the cigarette itself. Why don't in the past you talk about popcorn lung and e-vali? When people are smoking, why now you become so obsessed about vaping? Just because it's very sensational to talk about popcorn and to talk about e-vali. Well, in actual fact, you should actually talk long ago when people are smoking cigarette. So no doubt, we want to regulate all those. We want to make sure that the nicotine, the percentage of nicotine in the vaping itself must also be regulated. And it goes without saying, we only agree on medical treatment used for tobacco harm reduction. Thank you for your kind attention.